Let us now begin our next session. Molecular testing and diagnostic innovations are revolutionizing the field of precision oncology, offering personalized approaches to cancer detection, diagnosis, and treatment. By analyzing the genetic and molecular makeup of tumors, these advanced technologies enable clinicians to tailor therapies based on individual patient profiles, maximizing effectiveness and minimizing side effects. This paradigm shift towards precision oncology not only improves patient outcomes but also fosters the development of novel therapeutics and accelerates the pace of cancer research. And with this, let me introduce you all to this topic: molecular testing and diagnostic innovations, forging the path to precision oncology. Now, I'd like to welcome our panelists to join us on stage. Please welcome them with a huge round of applause. Dr. Maushami Suryavanshi, Head Molecular Biology, Amrita Institute of Medical Sciences and Hospitals. Dr. Vinay Bhatia, Head Molecular Biology and Genomics, OnQuest Laboratories. Dr. Debjani Saha, AGM, Primas Life Sciences. Dr. Shanmugapriya Chandrasekharan, Director and Chief of Product Development and R&D, Kriya Group of Companies. Dr. Udip Maheshwari, MOC, Cancer Care and Research Center. Dr. Chirantan Bose, Head of Department Molecular and Precision Oncology, MOC Cancer Care and Research Center. Please put your hands together to welcome all our panelists for this session. Now I request Dr. Bose to please take over this session from here.
Thank you. Thank you, Voice of Healthcare. And the post-glycemic sessions are usually have to be a little more fiery to keep everybody clued in. So I think great opportunity and a platform to discuss new science and precision medicine in its current applications, and having a great panel of experts here, which I'll take a minute to introduce. So I'll start from that side. Dr. Maushami Suryavanshi is one of the most decorated molecular genetic experts in the country, and I have had the opportunity to work with her many years back. Dr. Maushami heads the Department of Molecular Diagnostics in Amrita Institute of Medical Sciences. Thank you, Dr. Maushami, for joining.
Thank you, Voice of Health, and thank you, Next Stage. Thank you.
Dr. Debjani Saha is from Premas Life Sciences and has been part of an organization which has brought next generation sequencing to India. Premas has been the partner with Illumina from very early days. And thank you, Dr. Debjani, for being part of this session.
Thank you, Dr. Chirantan, and thank you so much to the organizers for having me here.
Dr. Udip Maheshwari is my dear colleague and one of the senior medical oncologists at MOC Mumbai. Dr. Udip is a DM in medical oncology. Welcome, Dr. Udip.
Hi, thank you. Thank you so much. Thank you, Viraj, for this platform.
Dr. Vinay Bhatia is representing the Reference Diagnostic Forum in the country. Dr. Bhatia leads the molecular department at OnQuest, which is, of course, one of the oldest molecular labs in India. Thank you,
Thank you
Dr.
so much. Thank you so much for having me in this platform.
Thank you. Dr. Shanmugapriya is part of the technical leadership of a very promising new company, Kriya Med, and I've been fortunate to know its founder, Ms. Anu Moturi. I don't know if she's there in the forum. And thank you, Dr. Shanmugapriya, for coming.
Thank you. Thank you, Dr. Chirantan, and thank you, VOH. Thank you, everyone.
So let's dive into today's session, which is really the applied part of molecular oncology. And there are a lot of burning issues in this, and we've been discussing through the day how the application in this science is emerging So let me start with the clinician here, Dr. Udip. Um, First of all, let the audience know from you what is the current cancer burden in India and how do you see cancer as a disease emerging in India? That's the first part of the question. And the second part is that how do you see molecular science apply in your practice, your patients in real world?
Correct. So we know that the data sets for cancer burden in India are generated by ICMR, Globocan, multiple. So there are about 10 lakh patients a year that are being diagnosed, roughly 10 lakh, and an annual increase of about 10%, 12% is seen in cancer burden, and the burden is continuously increasing, and by 2040 they have said that it will be threefold rise in cancer incidence that may happen. So the burden, and if you see clinically, when we see patients in our OPD, cancer burden is dramatically increasing every year, is what we, the perception of it is, right? We initially used to feel that the cancer is being diagnosed more, awareness is increasing, that is why the numbers are increasing. But I feel at ground level the rate of cancer is also increasing dramatically, and for that, these kind of molecular tests that we're developing now will definitely, from where we are 10 years back, now where we are, say a cure rates of about 5% to now a cure rates about 20% is a huge leap, and that the basis of that is molecular oncology, is the understanding of tumor better. And the second, to answer the second part of question, is that these molecular tests are very maybe 5 years back were not very commonly utilized by us, but nowadays with companion diagnostics, as discussed in the previous sessions, and plus smaller molecular panels, at least they have been made available to a lot of population. In fact, nowadays most of my people will get some form of the NGS, either a short panel or this. So it is a very core entity of my clinical practice, these small molecular panels at least.
Thank you. So, cancer burden is increasing, and the practicing oncologist is using it practically for more and more patients, for preferably every patient in their own practice. Thank you. Dr. Moshmi, coming to you. Now, let's talk about the problem. What do you see are the big challenges in application of molecular oncology in current day practice, especially in the Indian scenario? Out of pocket payment by the patients, less insurance coverage. What do you see is the challenge here?
Yeah, of course, as we know, cost is a big concern in our country. Then I feel accessibility of these services, that is another thing. And these are complex tests. So the complexity of these molecular tests is not very well understood by all. And of course, there is limited targeted therapy accessibility in the terms of clinical trials also. And I feel obviously the solution would be the cost comes down, which it has. If you see, I have been in this field for many years and I can clearly see the cost is coming down. But yes, it does need to come down even further. And then we need to educate the stakeholders, because they're daily, almost every 5 6 months, you have a new test coming, and you need to educate the people, the clinicians who are going to order these tests and how they will be useful to them. And of course, if we could have more clinical trials in India where the access to these drugs become free of cost to these patients, that will be very nice. And more of molecular tumor boards or some AI decisive decision making tools, if they are available, which can help. So that would be nice. And if the insurance companies also start including these tests in the reimbursement, so that would really help in the taking this forward.
So, thank you again. Key points: cost should come down, knowledge sharing should increase. And thank you for bringing those points. So, let us go to the cost center then. Dr. Devjani, You've seen really the trajectory of the first launch of NGS in India and where it stands now. What do you have to say about this trend, and how do you see it further evolving in the next few years to a decade?
Um, so of course, NGS use in clinical care or NGS use in clinical settings have obviously gone up. And just to quote a personal benchmark, our business almost about 5 years back also used to be predominantly academic research, right? Somewhere around 60 to 70% of our business used to come in from academic research sectors. Cut to present, it's the tables have turned, and it's 60 to 70% coming from clinical institutions or clinical, settings. So, of course, the adoption of next generation sequencing or cutting edge genomics in the clinical standard of care has increased. It's not meteoric, but it's been slow and steady. There are some factors which have really pushed it. First of all, I think the presence of these service providers or clinical service providers who were ready to make those big ticket investments quite a few years back. And they had a field force which could actually reach out and, like basically interact with the clinicians who probably did not have access to technologies and facilitate that access of technologies. I think they did a lot of ground work. B, I think over the past 5 years, we've seen an evolution of the analysis tools. So, like for instance, we have now processors. Earlier, exomes and genomes used to take days on end, weeks, days, months sometimes to get analyzed. Now you can actually have an exome analyzed in 20 minutes flat. A whole genome takes less than a day. So the analysis tools have actually evolved like multifold, right? The third thing, of course, has been COVID. I think COVID, in that sense, like before COVID, there were only 250, 200, 250 odd labs which were offering, let's say, anything even resembling like molecular diagnostics. Post-COVID, when real-time PCR became a household word, you had about 5,000 labs adopting at least real-time PCR, which was like one step towards that molecular diagnostic, road. So many of these labs, post the COVID surge, wanted to do something worthwhile, and several of them have actually crossed the chasm. And with the effect that now, because NGS is thought of critical, in clinical care, you have a lot of hospitals also setting up infrastructure to make these technologies available to the patient.
Great point. I think COVID has been a game changer. And analytics, what you rightly mentioned, we are going to talk more about it. Automation in analysis of broad spectrum NGS, we definitely are, relying on that. Reference diagnostic scenario, Dr. Vinay. You are in a diagnostic lab which basically brought a lot of molecular science in this country in terms of immunohistochemistry, flow cytometry, FISH, PCRs. And now we are talking of NGS. This whole session, I think, has been about NGS. How do you see, what are the factors where those technologies still hold valid, if at all? And how do you see the future? Where is the place of a FISH or an IHC with vis-a-vis NGS?
Thank you for the question, Dr. Boss. These conventional technologies, as per my opinion, still holds the same place as it was earlier. Reason being, these conventional technologies like PCR, FISH, karyotyping, and IHC have their unique characteristics. They have their clinical utility is well established, and they are very well validated technologies. These cannot be, of course, replaced by by keeping NGs in mind. These technologies cannot be replaced. Reason being, they are still as per guidelines. Few of the assays, if we say, are still being recommended by. If I take an example of PDL1, ISC is the most recommended technology. Similarly, for HER2/neu, we have FISH and ISC both. So in a scenario where only one particular targeted mutation is required, like for in case of CML, we have only BCR-ABL requirement. So why anybody would go for NGS when the targeted mutation can be done easily by a PCR with great sensitivity and specificity. Parallelly, cost is also an important factor, and TAT is additional contributing factor. So these technology will contribute equally in the complete patient for the patient for creating comprehensive report as a bundle. NGS will give a complete genomic profiling along with the these conventional technology. We would be in a position to give a better patient care, but we cannot replace these conventional technology because these are very well established and as a need of the hour in some scenario or case to case basis, these are still required and would be requiring in future as well.
Thank you. So, again, conflict between a conventional thought and emergence, but I do agree with her that there are certain single markers which are well validated on PCR or on IHCs, and of course, then there is the question of the whether NGS can, in a sensitive manner, pick up those large aberrations, which are more of the expression profiles, which are more of the. Yeah.
So just wanted to highlight, sorry for interrupting you, Dr. Randan. So there's classical example of ALK. We used to do it by fish, we used to do it by IHC. And I have had patients who've not had ALK picked up on fish and has been picked up on an NGS. And that patient who was started on chemotherapy has went on to an ALK inhibitor, survived for 3.5, 4 years, then succumbed with brain metastasis. But then that patient whose world had ended, saying that there are no mutations found on the IHC panels, and then we just got a fish done by Foundation One that time, and sorry, NGS done, and that showed an ALK mutation.
And we have an example where we have missed out mutation of
correct. So it could
EGFR
be
on
both.
NGS, which
Could be, yes,
clonal
absolutely.
population was less than 1 to 5%, or was between 1 to 5%, and we could picked up it using ARMS PCR. So
Yeah, correct. So no, so it's not. I'm not countering your point,
Yeah.
ma'am. I'm just saying that both
these
ways.
are the complementary
things-
technologies
Absolutely.
and
Can I
as
just
a bundle.
add to this for ALK from the technical side? For ALK, trust IHC more than NGS. Okay, I use NGS. I'm telling you, I've done this study. So if you have something on IHC and which is like with good controls, trust it. And as she rightly said, at times real-time PCR, especially when your tumor concentrate, this traction is less, may be much better because it may be beyond the sensitivity of NGS. But said all that, NGS is a complete package.
So you bring a very important point, and before we delve into another area which is very important, one line from you, when you compare an ALK NGS with a IHC, or for that matter an ARMS PCR, what are you concerned of on the NGS? Is that compromise on sensitivity or compromise on specificity?
No, it is not like that. There are some panels which are not picking the novel partners. That is one thing. And there are many of them. Okay. Your ALK IHC is looking at the protein expression. So it will pick up the abnormal expression. So that is one thing. So in fact, we did this study also, and I think almost more, there were 10 or 12 cases out of some 120, 30 cases which were not picked by NGS and which were positive on IHC, and they responded to treatment also. So that part you have to keep in your mind. And of course, in lung tissue is always a issue. So you don't know what reached finally, because once when you go for NGS, it is usually after you have done your IHCs and the tissue is practically depleted or on the verge of depletion. So that is the time. So that is also big concern.
So adding to Dr. Maushmi, recently I have released 2 cases. One was ALK fusion positive and one was RET fusion positive. My assay could not pick up. It was giving some imbalanced score, which was in the range of positive production. But since the counter partner was not included in the NGS panel, it had missed out. So in that scenario, I had to recheck on the fish technology, and accordingly I had to put remark on the report. So we have to have combination of all the technologies in place to give the complete information to the patient. So not we cannot say that one particular technology is sufficient enough to give the complete diagnosis.
And no test is perfect. That is one. When something has 95% sensitivity, we call it a good test. So that is the truth about it. So no, none of them is perfect beyond the other things, technical things which can go wrong. So otherwise also, if they are not gone wrong, still none of them is perfect.
And I think the list of technologies will keep growing because, in hematological cancers, now you also have structural variations coming in, which are the large structural variations cannot be detected by NGS. So you have to probably do something like an optical genome mapping
I know,
and
that has
stuff.
come.
So I think, the list is endless. You're right.
Long
it has
read
to be complementary.
sequencing, like it's coming, especially for hematological disorders. I feel short read will, long read sequencing will take over. Probably not for solid tumors because there's a lot of difficulty there. But things will change, and maybe a whole exome for hematology disorders where you don't have formalin would, you won't need a optical genome mapper because it will be cost effective also. It will happen maybe few years from now, and few I mean 3 4.
Thank you. Moving on to the pre-analytic discussions, we see from this panel of this side of the panel, which has already spoken, we see that the application is here and now. But when you look at India as a country and this entire map of the consumer and the provider, there are still, I would say, that the labs offering molecular testing, and from that also a small segment offering NGS, is fairly limited given the population of this country and the incidence of cancers. So, from a pre-analytic standpoint, what do you think are the considerations which are critical for sample transportation when you're looking at specimens flying in from Tripura to Mumbai and Delhi, or from Chennai to Delhi? How do you see, what are those factors which are important for these genetic samples to move?
Okay. So, if the question is about pre-analytical hurdles, as we all know, 60 to 70% of error in any testing, including molecular testing, would have happened in the pre-analytical phase. And that becomes even more crucial when it is molecular testing. Reason being, as you explained, there is a central processing laboratory wherein all these tests are being done, but the sample is taken and sample is fixated somewhere else, and then it is getting transported. So in that case, instead of me telling you about one biggest hurdle, I think I will be able to tell you few pre-analytical hurdles which are associated with both tissue sample processing as well as for liquid biopsy sampling. So to start with tissue sampling, it starts from the volume of sample that we need. That is not under control. The lab which is actually processing the sample, putting it into molecular testing, we don't have a hold on the volume of sample that is being sent. Because ultimately, the result that we get is dependent on both quantity and the quality of DNA or RNA that gets into the testing. And as far as quantity is concerned, it starts from the volume of specimen, and the general consensus is at least 1 centimeter tissue is needed, which is taken using an 18G needle. So that is a general consensus, and that should provide the adequate DNA or RNA nucleic acid that is necessary for molecular testing. And it's not just about the volume of the entire sample, right? It's also about the volume of neoplastic tissue that is present in the sample. And that is why CAP mandates that histology should report what is the percentage of neoplastic tissue that is present in the specimen. And that's why in all molecular testing reports, we would have seen the percentage neoplastic tissues 50% or 60%. And in this case, what is optimal and what is minimal? That is based on the sensitivity of the assay that we are looking at. And as we had an entire discussion few minutes back, for molecular testing, we will be dependent on multiple tests happening at multiple stages. So I'm going to consider NGS, which is considered to have the least sensitivity of all this. And there are many studies which say the sensitivity of NGS assay is anywhere between 3 to 10%, in the sense only when the tissue has got 10% of neoplastic tissue, it will be able to pick up mutations and pick up defects. And that can be translated. We might think, does that mean the neoplastic tissue content has to be 10%? It is not, because it should be able to pick up heterozygous mutation as well. So minimally 20%. The minimal requirement is 20% neoplastic tissue content, but the optimal would be 40% and above. So that's the second hurdle. Again, we don't have a control over that. And the third one is quality of the DNA. That is dependent on the degradation of nucleic acid that can happen. And degradation of nucleic acid, there are many factors which determine that. To start with two of the factors, the time gap between the sample extraction and the sample fixation, and the temperature to which it is subjected before fixation is done. And so there are many studies which have told various duration that can be allowed between sample obtaining the sample and fixating the sample. But if you're going to look at RNA extraction and studies based on RNA, they say it should not lapse beyond 4 hours. But again, we don't know what is happening there. So 4 hours, and anything which involves RNA should be immediately kept in ice. And interestingly, it is not just the time after the sample is extracted, because it's also dependent on the hypoxia to which the tissue might be subjected even before the tissue is taken from the patient. Which means, example, I was reading a few articles and few case studies. So there was a patient with liver cancer. Embolization was done, and after like 3 to 4 days, this tissue is taken. So degraded nucleic acid, embolization has killed degraded nucleic acids. So I feel that a molecular testing laboratory should have a sample form, and that sample form should have direct questions which will help us understand what could have happened to the tissue before the tissue reaches the laboratory. And apart from this, fixatives, right? So though the gold standard we say is fresh frozen sample, we know the cost that is associated with having a fresh frozen sample bank, and the logistics related to it, and that's why we go for fixatives. And again, fixatives, there are many types of fixatives. We all know this. Cross-linkage based fixatives or denaturation based fixatives, and we also have molecular fixatives, which are like pre-mixed solutions which come with proprietary composition. And if you ask me what is the holy grail that defines the best molecular fixative, I would say we should have in mind that the sample that is extracted is going to be subjected to multiple tests. First, it should be able to retain the morphology. Second, it should be able to retain nucleic acids, conserve morphology, conserve nucleic acid, and as we all said, IHC, so it should be able to conserve the epitope that is going to be tested in IHC. So fixative should be able to conserve all these three. And do we have such a gold standard fixative? The answer would be obviously, as Madam said, we don't have any test which is the gold standard test, which is a perfect test. Similarly, fixative, we have some fixatives which are good in one aspect, not good in the other aspect. For example, if you look at morphology, the best is neutral buffered formalin. That would be the best. But if you look at the retention of or the preservation of nucleic acid, we know it is not that great, because formaldehyde causes cross linkages with histones, which means retrieval of nucleic acid is going to be difficult. And it also induces variations in nucleic acids. But ultimately, I would say finally it is preferred. NBF is preferred because we have optimized extraction techniques. We have optimized, so even IHC, formalin is supposed to cause concealing of epitopes. But then we have something to retrieve those epitopes. And that is why mostly we are using formalin fixed FFP specimens for most of the molecular testing. And if you're asking me, what about those molecular fixatives that are available now? Those molecular fixatives are good. And the cost effectiveness is under question, and some of these molecular fixatives do not preserve morphology. So all these we have plus and minus, but we should understand what is a fixative that has been used for the particular sample. And then about how is it fixated, and then how about contamination. So all these are the pre-analytical hurdles which we don't have much of control over, but in the molecular testing lab we should have an understanding of all this. And that's about the solid tissue. My favorite one is liquid biopsy sampling, because I find that there are so many advantages in liquid biopsy. We have not yet ventured into it adequately, is what I feel. Reason is when it's liquid biopsy.
I'll have to push you, Dr. Shanmugapriya. What is your take for liquid biopsy? What is that best that you're looking for?
Liquid biopsy, yeah, we have two things. One is just collecting it in EDTA, processing it within 1 hour. But central processing would not allow it. And that is where we're going to have tubes with preservatives.
Right.
And with when it is tubes with preservatives, again, we should understand that just because it's collected in a tube with preservative, it cannot be held for long before the cell-free DNA is extracted. Maximum 3 days can be allowed between collection and extraction of cell-free DNA.
Great.
So,
yeah. So pre-analytical issues are important. It's important for everybody of the molecular science to understand that when we saw that Jurassic Park movie where they extract DNA from a mosquito which was preserved inside an amethyst crystal, that doesn't happen in the NGS world as we know today, because there is so much of DNA deamination which happens that reading the genomic sequence is very difficult in the real life if you have it preserved over a long period of time. So I think that was an introductory session. I'll have to request the panelists to quickly dash into the hard questions that I have in the second round, and just 1 minute from each of you on what are your thoughts on these. So thank you for bringing the liquid biopsy area. Liquid biopsies are being commonly used in oncology as of now, where you can take a liquid sample from a cancer patient instead of poking a needle into the lung to look into the tumor or in the abdomen or doing a brain biopsy. You can take small samples which are available in liquid form. Blood is the most common, but people are talking of other types also, like CSF, urine, etc. But blood is the most commonly used all over the world sample type for liquid biopsy as of now. We can do a lot of things on liquid biopsy, from tumor DNA to RNA, exosomal RNA, circulating tumor cells. Let me ask the medical oncologist, what is your thought on application of liquid biopsy in your practice, CTCs and ctDNA? Are you using it? What will the use increase in years?
Yeah, so for obviously the first diagnostic biopsies, we are doing a tissue biopsy for most cases, but ctDNA liquid biopsies are increasing. With the data set that is coming up, it is huge data set which is going to be validated in a larger way, and these tests will definitely help us with MRD detection. That is where I see that once we've given some therapy and if the tumor goes away, then the scans will tell you that only 4 mm, less than 2 mm disease will not be picked up on any scan. So whether these cells or CTC or a cell-free DNA are present in your tumor, in your blood, is something that is going to be the most MRD of is called minimal residual disease, which is present in hematological malignancies but not as yet proven in solid malignancies. So I see that CTC has a role there, and that is the way to treat most solid cancers in future. Second, CTC would also be helpful in patients who are difficult to biopsy, wherein we don't want to poke, as madam also said that tissue is always an issue in lung cancer, right? And many other cancers where you cannot biopsy them very easily, and those are the places where you can get them. Third point on liquid, very briefly, is in tumors where we don't need to biopsy, like HCC, like cholangio, where you cannot biopsy them. There you can get these liquid biopsies and get the tumor burden, so that we These tumor mutations can be used as research modules, as in we can have the data of how much, what mutation biology is there of these tumors, so we'll understand the mutational landscapes in these tumors where we don't biopsy regularly.
Thank you. So,
Can I add a comment? Actually, fortunately, I have been in a lab where we were the first one to do these things in the country. So first for CTC. So we were doing this. This is my own practical experience for breast cancer, prostate, and colon cancer. But unfortunately, we were not able to correlate it with the clinical picture. Okay, even though you were having CTCs, it was not clinically correlating well, and we were not able to answer that question to the clinician. So, what should he do with that report? So, in fact, so for this is for CTC, okay. But cell-free, I feel, became the game changer. So, of course, from the diagnostic to the resistance to the MRD to CSF, I have written papers on CSF extraction of cell-free DNA. It's a wonderful resource. So there's a lot to be done, and I will just say something which is not scientific or technical. And coming from me, I always say the definition of power has changed over time. So initially, it was the muscle power. The people who were physically stronger used to have it all. Then it was the wealth power, which still is. People who were richer used to take it all. But now I feel in today's era, it is the power of information. So, what your liquid biopsy does, it is not a replacement for tissue biopsy, it just adds to the information. So, more information you have, so you can make better decisions, and better decisions means better results. So, that's what happens when you have liquid biopsy.
sure, thank you. Liquid biopsies are a powerful tool. Of course, talking about liquid biopsy is a whole different session in itself. Circulating tumor cells, there are a lot of technologies which have come into play. Labs have developed their own technologies. I think it's the robustness of a technology that basically holds whether it can be used in clinical practice, whether it is in MRD, or in current times we are also seeing cancer screening through circulating tumor cells. You can actually take blood samples from healthy individuals and find out whether there are CTCs in that. So the applications are huge, but yes, we need to tread with caution. Coming back to you, Dr. Moshmi, that question of genomic profiling or molecular testing, small panel versus comprehensive panel, what do you think makes sense in clinical practice, given resources are not a constraint? Because we all know that if resources are constrained, the answers will be different. So, given resources are not a constraint,
she is smiling.
then what do you?
I think few days back finished a lecture on this. So any day, comprehensive genomic profiling. There are no two doubts. I will just give you an example because I think real life cases are the best things. So today morning we have been talking about patients who had ALK driver mutation and they were treated on these targeted therapies and they have been doing well just on tablet. You heard so many stories today morning. So I will just give you a case. This case came to me in January. So this patient was ALK translocated and had received 2 lines of therapy and not responded within 3-4 months, was not responding. And there was a NGS small panel which was done on this patient, and now the patient had come for comprehensive genomic profiling. So what we found was there was a germline HRD gene FANCA L mutation, okay, which was, there were other HRD genes also involved, and now patient was treated along with the ALK inhibitor with a PARP inhibitor.
Okay, get your point. So what the expert feels is that comprehensive genome profiling or CGP is the way to go ahead if resources are not a constraint. Does the medical oncologist agree? Just yes will do. Thank you. Difficult question to Dr. Debjani. Instruments, lab automation in India flourished from late 90s to late 2010 in the time that we all did our MBBS and MDs. reagent rental models came into play, where every lab, even in Jharkhand and Assam and Tripura and Mangalore, have got lab automation. Do you see that happening with NGS or not? And do you see that could be a constraint in the Indian scenario, where everybody may not be able to afford 1 to 2 crores for one piece of machine?
I'm not, I mean, they always say never. So probably it might happen at some point of time. The reason why it's not happened, A, is because, the reagent rental comes with a huge volume commitment. Any kind of a reagent rental will only work if there are volumes. And somehow, despite having a huge progress like I said, NGS being delivered to clinical care, we've not really reached those numbers. Like, imagine you have new cancer cases up to the tune of 1 to 1.5 million every year. You have 70 to 80 million rare disease patients. You have like literally 1 million plus TB patients every year. But like the total number of tests, NGS-based tests that are being done in the entire country over the span of 1 year is not even hitting 1 million. So we are literally scratching the surface. So unless the volumes come, reagent rental would probably be a little difficult, because I think it takes a lot to also support the infrastructure, from the point of view of a technology provider. So
I take your point. If volumes are there, reagent rental is possible.
So I want to congratulate you, and this was a very good one. He's asked the right person. They are the ones who usually don't offer reagent rental.
Okay, so I think that post this discussion, there is going to be another one outside the hall. So yeah. So Dr. Devjani, there are concerns about. I'm sorry, Dr. Vinay. There are concerns about NGS reporting harmonization. In the morning, also there were some talks that different labs have different formats of reporting. Where do you see, as a reference lab, what are the major aspects in harmonizing these molecular reports? Your 1 minute comments.
Yeah, so we know that NGS report is flooded with a lot of information in most of the cases, where we are getting information about what is the mutation, whether it is rearrangement or maybe it is gene fusions or something like that. But along with that, we are getting clinical information also. We are also getting what clinical trials which can be, patient can be enrolled in. But there is still there are gaps and challenges associated with the NGS reporting format. Reason being, there is a lack of standardized method of data analysis and interpretation. Lot of expertise and resources are required to churn out the data which we generate from NGS. Not all the laboratories are well equipped. Not bioinformatics, sophisticated bioinformatics softwares are required. Not all the lab are equipped with that. So that is the one major reason, I believe, which is and moreover, people need to follow the guidelines, clinical guidelines, recent guidelines for interpretation, and should be having enough knowledge about the clinical trials which are available. So main important point is resources and the use of appropriate updated bioinformatics softwares for data analysis. That is not available across the laboratories, so that is leading to variability across the laboratories as far as the reporting is concerned.
So harmonization of lab reports will come if there are equivalent reporting platforms, analytics platforms. Again, something which may go along with instrumentation. Totally point taken. Very quickly, Dr. Shanmuga Priya, the difference that you feel between the smaller tabletop platforms of molecular assay, real-time PCR or a digital droplet PCR, and an NGS, where do you see the bridge and where do you see the gap? Can we take another 2, 3, 4 minutes? Thank you.
Okay, so your question is about digital PCR versus NGS. So digital PCR, given the fact that we are talking about the third generation PCR, wherein we compartmentalize a specimen into multiple reactions and reactions happening independently, I would say, as previously discussed, both have their own advantages and disadvantages. Advantages of digital PCR would be number one, the volume of specimen that is required would be very less because the number of reactions is more. So we don't have to worry about the volume which I spoke previously. And the second advantage is sensitivity part. So as I told you, for NGS, the sensitivity is between 3 and 10%. But because so many signals are coming up and the noise to signal ratio for signal is high, the sensitivity can be as high as 0.001% in digital PCR, which means it can be used for cell-free DNA mutation detection. And the third one is it's an absolute quantification, it's not a relative quantification. So this can be used to find out absolute signals that come from, for example, HER2. So it is not just about IHC saying that there is HER2 expression. It is also about to understand the prognosis. If you can say what is the exact amplification of HER2, then you will be able to assess prognosis. So that quantification can be done here. And next is turnaround time. So we know NGS, of course, now the rapidity with which we get the report has increased. But when it comes to digital PCR, the turnaround time will be shorter, which means what we can do is those targetable mutations. For every cancer, we have a handful of targeted therapy. So those targeted mutations can be detected using digital PCR, and we can very well wait for NGS to give us additional information if we don't get any of the mutations here. So that we can initiate the treatment at a faster pace. So these are the advantages that I see for digital PCR, and disadvantages. If it's digital PCR, multiplexing in one reaction is not going to be possible because currently in every reaction it picks only 2 colors. Whereas if it's real-time PCR, we'll be able to do multiplexing. So if it's, for example, non-small cell lung cancer, we have around 10 to 11 mutations that we want to look at for targeted therapy. So that multiplexing is possible for real-time PCR, not possible for digital PCR. So these are the advantages.
Thank you. So,
just to add that the sensitivity of NGS can be increased with UMIs, and it can go up to the level of digital PCR and increasing the reads. So that is one point which.
But I think that point of the turnaround time and as well as the sample type, sample quantity, that those two are still some of the key factors which are important in having digital PCRs, especially in cases of lung where we have limited tissue content and limited sample type. So I think we are out of time. Thank you, panelists, for this very, very interesting discussion. I hope that the audience could relate to it. And thank you, Voice of Healthcare and Next Edge.
I'd like to thank the panelists for this engaging discussion. I'd also like to thank Dr. Bose for wonderfully leading this panel. Now I request Dr. Bose to felicitate his co-panelists. Dr. Mashumi Suryavanshi. Dr. Vinay Bhatia. Dr. Debjani Saha. Dr. Udeep Maheshwari. Dr. Shanmugapriya Chandrasekharan. Now I request Dr. Manisha Khurana to felicitate Dr. Chirantan Bose. Dr. Chirantan Bose. I request all the panelists to come to the center of the stage for a group picture.